Dr. Vivek Y. Reddy is Director of Cardiac Arrhythmia Services for the Mount Sinai Hospital, the Mount Sinai Health System, and the Leona M. and Harry B. Helmsley Charitable Trust Professor of Medicine in Cardiac Electrophysiology at Icahn School of Medicine at Mount Sinai. Under his leadership, Mount Sinai is the investigational site on several multinational clinical trials exploring new arrhythmia procedures and technologies. In 2014, Dr. Reddy implanted inside a patient's heart the world's first miniature leadless pacemaker, and in 2018, he performed the world's first pulsed field ablation procedure to treat atrial fibrillation. Hi, Dr. Reddy.
Hi, how are you?
I'm good. Thank you so much for being here. I know how busy you are, and thank you for taking your time out. This is going to mean a lot to a lot of people hearing from you. So I'm going to start right away. I'm going to ask you, can you kindly define electrophysiology? And in your answer, if you could somehow work in the difference between seeing a cardiologist and an electrophysiologist. I know that's just regular for you, basic stuff, but until I had my heart attack and then had an ablation issue, I had no idea of the difference. I saw the heart as one thing. So if you could just kind of tell about electrophysiology and that difference, that'd be wonderful.
A cardiac electrophysiologist is a cardiologist who's done additional training in electrophysiology. Electrophysiology is really the study of the heart rhythm. So, for example, a cardiologist may be focused on things like how are the valves working, how's the blood to the heart muscle going, that's the coronary artery disease, for example. Or if you have a heart attack, you'd see a cardiologist. A cardiac electrophysiologist you would see if you have rhythm issues. For example, if your heart is having extra beats or skip beats, or tachycardia, which means fast heartbeat. In that situation, you'd see an electrophysiologist. Electrophysiologists is also would be focused on slow heartbeats. So, for example, if one has a very slow heartbeat, maybe even fainting, for example, and requires a pacemaker, then that's another example where an electrophysiologist would be important.
It just seems that it's so pervasive, atrial fibrillation, that everybody knows somebody. My father had atrial fibrillation, he may rest in peace, had 3 ablations. But I wanted you to kindly explain atrial fibrillation, or AFib. What is the basic idea behind that?
Sure. So atrial fibrillation is one of the most common, in fact, it is the most common sustained heart arrhythmia or fast heartbeat. It's a condition that affects a lot of people. I mean, the estimate is actually pretty incredible. The estimate is somewhere between 1 to 3 to 1 to 4 individuals will develop atrial fibrillation sometime in their life.
Besides the genetics, what are the most common causes?
Yeah, sure, absolutely. So why, as you sort of intimated, you're hearing a lot of people are having atrial fibrillation. Now, almost everybody either has or knows somebody that has atrial fibrillation. Why is that? Well, I think there are a couple of reasons. Number one is that as our population gets older, and since AFib occurs in older people, the longer we live, the more likely we're going to have atrial fibrillation. There's a number of reasons for that, including the fact that as you get older, there's additional fibrosis or scarring that occurs in the top chambers of the heart, and that seems to predispose to atrial fibrillation. Number two, there are certain comorbidities that predispose to atrial fibrillation, meaning that there are other medical conditions like diabetes or high blood pressure which accumulate over time, affect the heart, and make it more likely for one to have or develop atrial fibrillation. And then there's another important issue, which is obesity. I think it's now well appreciated that overweight or obesity is a big problem, period, but particularly in Western societies. And as one gains weight, and particularly with more sedentary lifestyle, not exercising, there's again a higher incidence of developing atrial fibrillation. So all of these things sort of conspire, I think, for us to see atrial fibrillation more and more in individuals.
Are there other lifestyle changes that somebody could get ahead of, even if they're having it proximally, intermittently, not all the time, to try to slow it down, or even once you start to develop it, is there anything you could do naturally that you know of that would at least slow it down, the progression? Less caffeine maybe, or alcohol, or...
Yeah, no, it's a great question. So we know that atrial fibrillation typically starts in an intermittent fashion, meaning a little burst that stops by itself, and over time it can get longer duration, more frequent. Once that starts to happen, there are a couple of lifestyle things that one can do. Probably the most effective is cessation of alcohol, or at least minimization of alcohol.
Wow.
There's now very, very strong evidence. It's very clear, and in fact, most people that have AFib know this from their own sort of personal experience, that if you drink alcohol, it is almost certain that you will increase your chance of having an episode of atrial fibrillation.
Wow.
And again, it's not that alcohol is the cause of AFib, because it's not, but it's a trigger. So, and it occurs, by the way, in a quote-unquote dose-dependent fashion, meaning that if you drink, for example, 2 glasses of wine, it's more likely that you're going to trigger an episode of AFib than 1 glass of wine.
Oh.
And how does it happen? Oftentimes the episodes will happen not necessarily while you're drinking it, though that can also happen, but oftentimes it'll happen later, maybe that evening or in the middle of the night after drinking a couple glasses of wine, for example. And dehydration also seems to play a role, by the way. So the combination of drinking alcohol and dehydration. So if one has atrial fibrillation, certainly avoid binging. I mean, that is very, very clear.
Right.
But also, decreasing the amount of alcohol that you consume can actually have an important impact. Now,
but if you did drink anyway, not crazy amounts, and you did try to hold it down, would introducing more water into your diet when you're drinking help?
Yeah, definitely stay hydrated. So, if you happen to drink a glass or two, drink an extra glass or 2 of water that night before you go to bed. I think that actually will be important. Now, there are other triggers also. I focused on alcohol because it's the most prevalent and probably the strongest trigger. But there are other environmental triggers. The one that most people think about are things like caffeine. Now, as it turns out, caffeine actually is, in most individuals, is not a trigger for AFib, in most individuals. But there are exceptions. There's some individuals where caffeine actually is a trigger. And what we know is when a patient has one thing that's a trigger, like caffeine, for example, that tends to be a recurrent trigger for that person. If, on the other hand, it's not a trigger, then it tends not to have an impact in the future. So I think caffeine certainly is important. And then there are other general things. I mean, smoking is definitely not good. So cigarette smoking is bad for so many reasons, including atrial fibrillation. There's no doubt, there's actually very good data that when an individual has paroxysmal or intermittent atrial fibrillation, then exercise, staying active, reducing weight, those things, while they may not cure the AFib, they can substantially reduce the burden or the amount of atrial fibrillation. In addition to it actually happening, there's also the fact that we're diagnosing it more frequently. And there are a couple of reasons for that. One of them is, as I intimated earlier, the advent of smartwatches and other sort of technologies that are consumer technologies, where one can identify what exactly is happening to their heart. They may feel, oh, there's something irregular going on, and in the past you may just sort of ignore it. But now people are wearing watches, and sometimes even wearing them when they sleep, and the watch informs them that, oh, you know what, there was something irregular overnight, for example, or while you're wearing it. And that brings patients to our attention, I think, a little bit earlier. So I think, I think so there's a number of different reasons why we're seeing AFib. And as you said, it's almost like an epidemic, individuals that have it. In the past, we used to think that atrial fibrillation is only important if it's causing symptoms, okay? But now there's one major study and a couple other smaller studies that have demonstrated that no, atrial fibrillation is bad for individuals even if it's not causing symptoms. So now it's not just about symptom control, which is obviously important, but actually rhythm control. So we now know that getting people and keeping them in regular rhythm is a good thing. It improves longevity, it improves, even on top of blood thinners, it decreases the risk of stroke, heart failure, etc. So that's an important point.
Do you need to exhaust medications before you move to the procedure? Because I know in my case, I had the option, and I did try a beta blocker. and it made me feel uncomfortable. I didn't like living at a slower heart rate. So I opted to have the actual procedure. Is it better to first try medication, or is it okay to go right to the procedure?
Yeah, no, so let's talk about treatment as you're talking about. So I think the first point I just want to make is, one of the worst things about atrial fibrillation is the increased risk for stroke. So I just want to emphasize that when one has atrial fibrillation, one needs to be assessed for what is the risk of stroke, and if the risk is high enough, to consider being on a blood thinner. So I just want to say that at the outset. When one has atrial fibrillation, oftentimes we start off with medications, and there are a range of medications. As you can imagine, there are the medications that are very well tolerated, extremely safe, but tend not to work as effectively as other medications, which are much stronger, much more effective, but also have other side effects that can sometimes be very important and sometimes, frankly, even be dangerous. So there's a whole sort of range of medications.
Okay.
And then there's non-medical approaches, or non-medication approaches, I should say, like catheter ablation, which we're increasingly using. It used to be that what we would do is try patients on medications, and we'd try one medication, and if it failed or if the patient doesn't tolerate it, then we go to a stronger medication, perhaps. And then if those failed, then we'd go to catheter ablation. There's some caveats there, by the way. For example, if one has a baseline low heart rate, then many of the medications we use can't be used because they further decrease the heart rate. So in that situation,
well, that happened to me with the beta blocker.
Yeah, exactly.
I passed out.
Right.
Yeah.
And that can certainly happen. In that situation, we would say, you know what, the medications aren't going to work, period. So one way or the other, we oftentimes, in many patients, not everybody, but in many patients, would end up with catheter ablation after failing medications. But that's sort of changing now, and there are a number of reasons we can go into that. But we're now using catheter ablation earlier and earlier in the disease state, or the disease, let's say, progression. And there's a number of different reasons for that. But now, oftentimes, patients who come in with paroxysmal or intermittent atrial fibrillation will consider ablation even as a first-line approach. Now, that doesn't mean that you have to have an ablation. It certainly is reasonable to try a medication if that's what one's preference is. But it also means that, we have many patients who come in who, for various lifestyle reasons or other reasons, don't want to be on medications and opt for ablation even as a first-line strategy. And that certainly is reasonable.
I wanted to ask you, this leads perfectly into ablation itself. And I had read that ablation is basically a controlled cell damage, a way of trying to create a roadblock, if you will, so the failed electronics can't get to the spot that it's getting to. Can you kindly explain that before we get into the difference, the thermal and the pulsed field type of ablations? Can you just give a basic understanding of the idea of ablation itself?
Yeah, sure. Ablation is exactly as you said. It's basically is destruction of tissue. Okay, just like, for example, when you do surgery and you make let's say a surgical incision, you're cutting that tissue. And ablation is a very similar concept where we use catheters. So these are these long wires that we introduce through the veins in the leg into the body, and we maneuver these catheters inside the heart, and we go to different locations and we deliver energy, and that energy basically destroys that tissue. Now, why is that a good thing? Well, in people with atrial fibrillation, the problem in most people with atrial fibrillation is that there are these foci, or these triggers, let's call them, that are firing so fast, some abnormal tissue, that causes the atrium, so it's not, the electrical impulses aren't traveling in a coordinated fashion, but in a very irregular fashion. And that irregular, fast rhythm is atrial fibrillation. So what we do in broad strokes is, at least the majority of what we do is we maneuver the catheter in the heart to the locations that are causing the problem. And in most patients, there are these locations called pulmonary veins, which drain blood from the lungs back to the heart. But as it turns out, in the walls of these veins are these triggers that can induce the atrial fibrillation. So what we do is we take a catheter and we deliver energy around the pulmonary veins, and that basically creates a ring of scar tissue through which the impulses can't travel into the heart and cause atrial fibrillation. Now, that's not everything. There's other places that we also ablate. It's a little more complex than that. But that's basically the the harder the matter, so to speak.
I want to now just bridge into different types of ablation. I know there are many, and there have been different kinds in different countries. But I know that here, and what I had, there's thermal. There's two types of thermal. There's the radio frequency, which I had. There's cryoballoon. And then, of course, there's pulse field, like we'll talk about. But I was hoping you would explain radio frequency, because I'm talking to several doctors, and some of them still feel that is the way to go. And I just was curious on your thinking of radio frequency ablation.
Yeah, sure. So, let's talk about radio frequency and thermal in general. Whether radio frequency is basically burning tissue, so you deliver energy which basically heats up to cauterize the tissue. Cryoablation, conversely, is cooling the tissue, so basically freezing the tissue to such a low level that also can destroy tissue. Both of them are thermal ablation. So what that means is the way the tissue is being destroyed is by heating or cooling the tissue to a point where the tissue gets destroyed. And they're very effective. We've been doing the thermal ablation for many, many years, and certainly that's what I did for the first couple of decades of my practice. But they're not perfect approaches. One of the issues with thermal ablation is that it's relatively tissue non-specific. What that means is, as the energy, the heat wave or the cold wave for that matter, as it enters tissues, it ablates the tissue, okay? And that's good for the heart tissue that we're trying to ablate, but it's not good for any additional tissue beyond the heart wall. So as you're delivering energy into the heart tissue, as that thermal wave propagates and ablates tissue, the good, until it reaches the end of the heart wall, for example, that couple of millimeters thick, and then there's additional structures beyond that that can also inadvertently, inappropriately get ablated, and that can cause certain complications. The most dangerous of those complications, by the way, is if the thermal wave hits the esophagus, which resides behind the heart as it goes from the mouth to the stomach. And if it hits the esophagus, and in a small percent of patients, that healing can be aberrant, and you can end up with something called an atrial esophageal fistula, which is basically a hole between the heart and the esophagus. And it is as bad as it sounds. That is a catastrophic complication with a very high mortality.
Is there a high percentage of that? Because I really would hate to scare people too much.
No. That's what I was going to say. It's not very common, thankfully. Okay, so that's the good news. It's quite uncommon, infrequent. But the bad news is when it happens, it is quite deadly. Okay.
Oh.
So that's but again, it's not common. And there's various precautions we take during the procedure to mitigate the chance of this kind of really horrific complication. It can cause something called pulmonary vein stenosis or phrenic nerve damage. Pulmonary vein stenosis means that as you ablate the veins, they can actually get more contracted or smaller. If they get a little smaller, honestly, it doesn't mean anything. But if they get significantly smaller, then that can cause impediment of blood flow, which can cause shortness of breath and other problems. You can also cause damage to the phrenic nerve, which is a nerve that runs on the right side of the heart.
Okay.
And if that gets damaged, then the diaphragm is not moving normally, so that can impair the breathing. Now, oftentimes that heals over time, usually months to maybe a year, but in the interim...
Can I say something?
Yeah.
I actually did have that, the phrenic nerve, because all of a sudden one day I was on set doing what we do, and I couldn't get a breath. And I felt like I couldn't take deep breaths. And so my cardiologist said, give it some time. There's not that much damage, but there's a lot of swelling.
Yeah.
So it did come back, but it took about a year.
Yeah, that's not uncommon.
Very frustrating.
Yeah, again, it's one of those things, fortunately, it doesn't happen that often.
Right.
But it happens a couple of percent of patients, which is not trivial. And when it happens, as unfortunately you found out, it's not good. It doesn't feel good. I'm glad it came back. Again, we want to try to avoid this, and these are reasons why pulse field ablation.
So, perfect bridge. So pulse field, from my understanding, a layman understanding, is that it is cell specific, is that the pulse field of DC current every cell has its own level that it will take to kill it, ablate it, create that scar tissue. So instead of it going out like thermal and attacking everything, it will only kill what you're attacking. It won't attack anything else and kill it. I know that's very blasé explanation, but if you could kind of expound on that, it'd be
Sure.
great.
Yeah. No, it's pulse field ablation, as you just intimated. It is, by the way, quite new, but it's actually not that new. Believe it or not, the very first ablations ever done. Okay,
80s.
they were actually done for ventricular tachycardia, but the very first ablation was actually an early form of pulse field ablation. It's called DC shock, and now it's much more controlled, as you suggested. And yes, now pulse field ablation is different for a couple of reasons. Number one, it's fast. Okay, so unlike thermal ablation, which can take time, and when I say time, it may be 30 seconds, 60 seconds to deliver a lesion. And that may not sound like long, but when you have to deliver 40, 50, 100 lesions, that adds up, and that prolongs the procedure time. Pulse field ablation is very quick. It's either instantaneous or a couple of seconds at most. And the way that works is, instead of using temperature to destroy the tissue, it creates this electrical field. And as you said, some cells are more sensitive to that electrical field than other cells, okay? And that electrical field that's encompassed within that zone of, the cells that are within that zone of the electrical field get ablated. The ablation mechanism, again, it's not temperature. It basically, there's a number of different mechanisms, but it basically punches holes in the cell membranes and destroys that tissue. Why? There is some degree of tissue selectivity to pulse field ablation, as you intimated. We don't fully understand all the reasons for that tissue selectivity. Frankly, some of this is still being worked out. But now we know, with literally tens of thousands of patients that have been treated, now we know that pulse field ablation has important safety advantages. The risk of atrial esophageal fistula, this really horrific complication we're talking about, doesn't seem to happen. I mean, there's yet to be a single case of atrial esophageal fistula with, 70 or 80,000 patients who have undergone pulse field ablation. Phrenic nerve palsy, the damage to the phrenic nerve. The risk is probably not zero, but it's pretty close. And when there's damage, it appears to come back relatively quickly, usually within a day, or even less than that.
Wow.
Or pulmonary vein stenosis, that does not happen at all, period. So there's a number of safety advantages that pulse field ablation seems to have. So when you combine the fact that it's fast, there's these safety advantages, which, again, even with conventional ablation, with all the precautions we take, we avoid, it's not like we have a high risk of complications, but they can happen. With pulse field, some of these complications can happen, period. There's also, as it turns out, and this we're still sort of understanding, there also appears to be an effectiveness benefit. So some of our earlier clinical studies indicated that pulse field ablation is as good as conventional ablation. But some of the newer studies are indicating that no, it's not just as good, it's actually better than conventional ablation.
In what sense? A scar tissue is scar tissue.
Yeah, that's right. But the question is, did you make effective scar tissue with your ablation lesion?
Okay.
So the problem with thermal ablation, whether it's radiofrequency or cryo, is the physicians are always trying to maximize effectiveness and safety at the same time. I mean, we're trying to do that with everything. But with thermal ablation, you can get a better lesion if you go on longer. Okay, just in a very simple scenario. But the longer you go on, the higher the risk of causing some problem, clot formation or something bad. So, obviously this has been honed over time to maximize safety and effectiveness, but there's still that balance between safety and effectiveness. With pulse field, of course, there's still a balance, but it's because the safety is so much better, you can deliver, for example, extra ablation lesions with minimal time penalty and basically minimal to no safety penalty. So by consolidating your ablation lesions quickly and et cetera, we seem to be able to increase the quality of the ablation lesions.
My father, I mentioned earlier, I think for a second, may he rest in peace, had the 3 ablations. The first did nothing. He had them a long time ago, and that's because obviously they didn't correctly get the scar tissue. They were playing it safe, didn't want to create any other damage, and didn't deliver enough energy, so we had to have it done over and over again. Has that been kind of figured out with pulse field? Is one application with the electroporation, little holes it's making in the cells, does it always work to create scar tissue, or is it still a learning curve?
Yeah, it's a good question. This is a rapidly moving field, I gotta say.
Okay.
The first generation pulse field ablation catheters are much better than what we had in the past, but it's not perfect. So let me be clear about that.
Okay.
The pulse field ablation catheters right now are quite good, but they're not perfect. And in fact, there are second and third generation pulse field ablation catheters already being developed in early clinical studies that are going to, before maybe we were 60 to 70% durable lesions. Now we're sort of in the 90% range. But to get to 100% is probably going to require these second and third generation technologies. But the point is, the path to 100% with thermal ablation was never clear to me. It wasn't clear to me that it was ever going to happen. Okay, I mean,
right.
you may get 100% with certain expert operators and et cetera, but in terms of getting the whole field there, it wasn't clear to me that we could ever do that. With pulse field ablation, it is very clear to me that we will be able to do that.
I had a 25% burden for PBCs around my mitral valve. And I was looking at cardiomyopathy, straight in the face, and he said, you have to have this done. It's a basic procedure, but it's a little more complicated where we have to go to get it. So they got it, and it brought my burden down to 2%. But as of late, they're starting to ramp up. And I recently spoke to my doctor, who said to me, we might have to put a monitor and see if we got it correctly. If that is the case and they did not get it correctly, PVCs, am I a candidate for pulse field?
Yeah, great question. So right now, we don't have a catheter in the United States that's approved, a pulse field ablation catheter that's approved for ablation in the ventricle. Okay.
Oh, okay.
But let me just but that's changing rapidly. All right, we're going to have catheters later this year, that pulse field ablation catheters that likely will be approved in the United States later this year, that we can use for ventricular ablation, for PVC ablation. And
Okay.
there are some real advantages. I mean, we know from preclinical studies that pulse field is particularly effective compared to conventional ablation in the ventricle also. So there's some real advantages. So I think, for you and for individuals like you, if you need another ablation procedure, for example, for PVC ablation or other ventricular ablation,
Leave the
stay
country.
tuned. Well, no, I would say stay tuned, because certainly there are some of these devices get approved in Europe before the US, but we're just on the cusp, literally within a month or two, of having technology that we can use in the ventricle in the United States. So I think that's a real advantage for patients. So we're very excited about that. And then on the effectiveness side, so AFib is quite effective. AFib ablation, that is quite effective. So everyone wants to know numbers, of course, understandably. So people with intermittent AFib, the success rate is around 80%, plus minus. Okay. Now, what does that mean? Okay. So in every clinical trial that we've done, we've used 30 seconds as sort of the metric for success or failure, meaning an episode that lasts more than 30 seconds. What that also means is that many patients that we would qualify as a failure may not have clinically significant AFib. And let me give you an example. Let's say we do an ablation in a patient, and let's say 12 months or 15 months down the line, they have a 5-minute episode of AFib. Okay? In every clinical trial that's been done, that would be deemed a failure. Okay? But that's still a vast improvement for almost anybody who presents to us for an ablation procedure.
Sure.
Because when you look in patients who have, let's say, implantable devices where you can carefully calculate the amount of AFib they're having, what we see is that catheter ablation reduces the amount of atrial fibrillation by 99%.
Wow.
In people who have intermittent AFib. So the success of the procedure, even the so-called failures, are oftentimes quite successful. So, and this is important, by the way, because the burden of residual atrial fibrillation is what tracks with adverse events and consequences, like symptoms certainly, but also residual risk of stroke, of heart failure, all these other negative consequences.
Can you explain to anyone that's considering an ablation what life after an ablation is? Are there any additional restrictions that you would do? I mean, of course, they're part of the lifestyle changes anyway that you should be doing. But after an ablation, I'm living I'm living a very normal life, and so I'm just curious on what you would tell your patients as far as what is life like after an ablation.
Yeah, I can separate that to the early after and let's say late after. So
Please.
Early after ablation, days to weeks, there can sometimes be a little bit of irritation from the ablation because, ablation causes some inflammation, which is normal, and that can cause some irritation. So you can have some extra beats or even short episodes of AFib that occurs early after the procedure. And then that tends to die down over the first couple of weeks. Okay, that's an inflammation-related phenomenon, and there are ways to mitigate that. And then there's late after. So we tend not to worry about what happens in the first few weeks and maybe a month or two. But after that, then we really are paying attention. And again, there's some patients where maybe the lesions weren't durable and maybe they need a second procedure. But in most patients, after the ablation and after the acute phase, things tend to be quiet. So they don't have the atrial fibrillation, obviously. And then you get back to your regular sort of life. In fact, we want you to not just get back to regular, but even be more active and get back to doing things that sometimes patients don't do because the AFib is inhibiting them. Now, one of the questions patients always ask is, well, what about the medications? Can we stop them? And
Yes.
The answer is, and let's separate these into the different types of medications. So the medications being taken to try to control the AFib, like the antiarrhythmic drugs, the beta blockers, or other medications like that, those we do tend to stop. We may want to continue it for the first couple of weeks after the ablation, but after that we tend to stop them. Okay.
Okay.
But what about the blood thinners? So blood thinners, as we talked about, are oftentimes used in patients who are high risk for stroke. Immediately after the ablation, everybody stays on the blood thinner for a couple of months. Okay. After that period, then the strategy that we the general strategy that's that we use is to continue the blood thinner based on the baseline risk of stroke. Okay. Now, there's a little bit of cognitive dissonance there, right? So if we did the ablation and we got rid of the AFib, why in the world would we want to continue the blood thinner? It makes no sense, right? Well, there are a couple of reasons for that. The main reason is that we worry about the possibility that in the future, what if you have more AFib? Maybe it's even silent AFib. Maybe it's happening while you're asleep, for example, okay? And if you have other comorbidities that put you at a higher risk for stroke, then we may want to continue the blood thinner as a way to mitigate that risk, okay? Now, the question is, what is high enough risk? And that's something, every individual patient is a little bit different. I do want to say that this is a very dynamic field. There's lots of clinical studies and important clinical trials happening, and in the next year to two, we're going to have a number of studies. Well, there's one major study and some smaller studies looking at the safety and effectiveness of stopping blood thinners after ablation. These are pretty big studies. So we're going to have more information, but in general, the blood thinners in patients that are low risk or maybe intermediate risk will stop. In high risk patients, right now, the general strategy is to continue. In the future, that may change.
My final question is kind of a role play. I think you might have covered it already, but if I was a patient coming to you, and I'm a patient to you right now, and I know you treat all your patients the same, whether it's a parent, a friend, a loved one, or someone you just meet. If they said to you, listen, I'm having intermittent, occasional AFib. I really don't want to start the medication, but I'll do whatever you say, but I'm afraid of having somebody do some procedure on my heart. And the idea of having anything destroyed in my heart is kind of frightening. What would you say to them as far as safety and overall longevity?
Yeah, a couple of things. So first, what you said, by the way, every patient is thinking that. Okay, they may not always articulate it as you did, but everyone is thinking that naturally, obviously. So what I would say are a couple of things. One, every patient is different. For example, patients who have heart dysfunction, let's say heart failure or cardiomyopathy, okay? In those patients, getting rid of the AFib is particularly important. It even has
Sure.
important short-term, even mortality benefits potentially. So that's a slightly different population than most patients who don't have other heart dysfunction. It also is modulated by, as we talked about earlier, or even a candidate for other antiarrhythmic drugs because maybe your heart rate is too slow. Or you have other comorbidities, like let's say a previous heart attack, which disallows you from taking certain antiarrhythmic medications. But let's say both are options. Okay, you can take drugs or you can have an ablation procedure. Then we can look at what is the character of the AFib. For example, are the episodes really short episodes, pretty infrequent, or are they episodes, let's say maybe they're infrequent, but they're increasing in frequency, increasing in duration? Because
Sure.
before intermittent AFib, as it goes to persistent or continuous AFib, it tends to become more frequent and it tends to become longer duration, particularly when the episodes are starting to reach 24 hours or even longer duration.
Yeah.
Then we worry, you know what, this may start becoming persistent. Or if we have a monitor and we see that the burden of AFib is starting to reach, let's say, 10% or higher, that's a pretty high burden because AFib, it doesn't go from 1% to 100%. It goes 1, maybe to 10, maybe 15, and then tends to jump up to 100%, okay?
Yeah.
So these are all the things that we think about. But ultimately, look, it is reasonable. I tell my patients, if you're trying to decide whether to go to ablation or drugs, just try the medications because, you know, we as doctors are not very good at predicting how well a patient will, number one, tolerate the medication, and number two, how effective the medication is. And there's nothing wrong with trying the medication. Try it. Some of my patients will come back to me and say, literally within days of starting it, they'll call and say, you know what, I don't want to take this thing. This is making me feel tired or whatever. I want to move forward with ablation, and that's okay. Other patients who are not sure, they may take it and they may feel fine. The medication is not causing a problem. It's suppressing the atrial fibrillation. And in that situation, then we follow the patients, make sure it really is suppressing, that we're not having a lot of asymptomatic AFib, and then just continue. And now at some point, the disease process may progress where the medications then stop working. And at that point, we may go to ablation. So I think that that's really the perspective. I mean, the reason why most of my patients, by the way, do tend to go toward ablation earlier. And there are good reasons for that. Part of it is that one thing we do know is ablation is just more effective than drugs. Okay, so
Sure.
many patients just want to sort of get it done and not worry about all this other stuff, and that's okay. Ablation is also more effective in preventing the progression of the disease process, going from intermittent to persistent. So for these reasons, we see more and more patients opting for ablation, either early or soon after trying medications.
Thank you so much. I mean, wonderful talking to you. I could talk to you for hours. I just find you just so engaging. And thank you for taking the time. I know how busy you are. And maybe I'll be knocking on your door for that procedure soon enough.
No problem.
But thank you so much for your time.
Absolutely. Very nice to speak with you.
Thank you, doctor.